Good afternoon, I should say. This day's going by so fast I still think it's morning. My name is John Crutchman, Director of Continuing Education for the Missouri Institute of Mental Health. I want to welcome everyone here today. This is the first of our 28th annual, I guess, Visiting Speaker Series. A formal brochure will be out in a couple months. We'll cover a spring series. We will have some individual flyers. You probably saw some out there on the table. We'll have some individual flyers for some talks between now and then. Our speaker today is Dr. Frank Masur. He's with Health Psychology Associates in Memphis, Tennessee. For the past 10 years, Dr. Masur has served as the Director of Health Psychology Associates, a private practice specializing in the diagnosis and treatment of stress-related physical disorders. He's published numerous scientific articles in both the medical and psychological literature and has lectured nationwide on healthcare reform, specifically on the aspect of cost-effectiveness of providing timely mental health care. He has served as a consultant to numerous corporations, including FedEx, Hunter Fans, Schering Plow, and the Upjohn Company. After his postgraduate education, Dr. Masur joined the faculty of the University of Tennessee Medical School. He held appointments there as associate professor in the departments of family medicine and psychiatry. He's also an adjunct professor in the Department of Psychology at the University of Memphis. He completed his undergraduate training at Marquette and received his PhD in clinical psychology from St. Louis University right here in town. He did his internship and fellowship in medical psychology at the Duke University Medical Center. I jokingly said to him today as I met him again, because he was here, I think it was 3 years ago, probably in '92 for a lecture, and we chatted for a while afterwards, and standing outside the door of our office, I remember talking to him and him saying to me, you know, I've started giving a talk on managed care, and it has the phrase, the buck stops here in it. And so I told him, I said, if you ever think that things you tell people aren't remembered, don't believe it, because 3 years later, as we were talking about speakers and talked about getting someone to do a managed care topic, I said, I know just the guy who could handle that. So he's here today to talk about timely mental health care delivered in a cost-effective way and how that can substantially reduce or offset the overutilization of medical health care expenditures, as well as some of the obstacles to achieving that. I would ask you to save your questions to the end. Dr. Masur will be showing some video clips, and we want to be sure to have time to do that. And there will be time for your questions at the end. And immediately following this, there will be a very informal reception downstairs in the MIMH library. If you've never seen our library, you should join us there. It's a very fine behavioral sciences library, and it'll give you a chance to chat with Dr. Masur a little further. Dr. Masur.
Thanks so much, John. I heard a story the other day about three physicians who were in a plane crash, and as they all made their way up to the pearly gates, St. Peter asked the first one, "Why should I let you in?" He said, "Well, I'm a very famous cardiologist, and I've saved literally thousands of lives." St. Peter said, "That's fair enough. Enter." Second physician came up, and he said, "Well, why should I let you in?" He said, "Well, I'm a very famous clinical researcher. Because of my research, literally tens of thousands of lives were saved." He said, "Good enough. You're in too." Third doctor came up, and he said, "Why should I let you in?" He said, "I was the clinical director of the largest managed care program throughout the country." St. Peter said, "Very impressive. I'll allow you in too. 2 days, then you're out." We're going to look today about how mental health care, which sometimes I think is the stepchild of health care, actually, when you provide it in a very timely and effective way, reduces cost in terms of overall medical utilization. Before getting into that, let's just talk a little bit about some of the basics, though. First of all, we know that in the 1990 numbers of the $660 billion that was spent on overall health care, only 15% of that actually was spent on mental health care. And even a smaller percentage, only 5%, was actually spent on outpatient mental health care. I'm not saying mental health care is cheap. In fact, in the old days when we had the psychoanalytically oriented therapist seeing the patient 3 times a week on the couch, it was quite expensive. And to some extent, I guess it's still expensive today. In fact, if we take a look at some of the numbers, here's what we find. Of the $67 billion that was spent on mental disorders, and we're going to look today at the anxiety disorders, about $10 billion is actually spent each year on the direct cost of treating those disorders. But that doesn't tell the whole story. As a matter of fact, with most mental illnesses, we find that there is a huge expense in terms of the indirect cost of mental illness. And again, looking at the anxiety disorders, we find that we spend almost 3 times more money, $35 billion, when we look at the indirect cost of the anxiety disorders. And indirect cost includes things like lost earnings, decreased productivity, morbidity, and mortality. Some of this is old news to you. If you look at the ECA, the epidemiologic catchment area studies, we know the epidemiology of these disorders. And in fact, your lifetime prevalence of having any mental illness is about 1/3. Of having an anxiety disorder is about 15% lifetime prevalence. Actually, we should adjust that up slightly to about 20% because in this particular series of studies, they left out generalized anxiety disorder, post-traumatic stress disorder, and some others as well. So this number really should probably be about 20% lifetime prevalence. My pitch today is basically this, that if you provide timely mental health care, you can substantially reduce untimely physical or medical care. When you look at the ECA studies, and you look, for example, at the anxiety disorders and the 13 million Americans who suffer from it, it's quite interesting because only 25% of those people are actually in treatment. And of that 25%, 40% of them are being treated by their primary care physician. It's either their family physician, it's their general internist. In the case of children, of course, their pediatrician. In the case of many women, it's their OB-GYN. So here we have a real underground, if you will, of mental health and mental illness, since most of the mental health that's actually being provided in this country is being provided by non-mental health specialists. In fact, if you take a look at the data on psychotropic medications, about 70% of the psychotropics written in this country are written by non-psychiatrists. Why would this be? Well, again, just looking specifically at anxiety, it's no great surprise because this is a disorder that usually presents initially with physical symptomatology. Here's just a partial listing of the cardiovascular, pulmonary, gastrointestinal symptoms that a patient with anxiety may present, genitourinary symptoms, and symptoms of the central nervous system. So as a matter of fact, patients present to their family physicians quite frequently with anxiety. I heard a joke the other day about the family physician who kept getting called in the middle of the night. An elderly woman just kept calling him. She said, "Doctor, I'm just so anxious." And he said, "Well, ma'am, what seems to be the problem?" She said, "Well, I don't know how to put this tactfully, but there are 2 dogs and they're mating on my front yard and it's just making me very nervous." And he said, "Well, ma'am, I don't know what to tell you. I mean, you certainly don't need medication. I'll tell you what, just grab a hose and squirt them down. That'll separate them." She said, "Thank you so much." Well, of course, an hour later, she called him back. Said, "Doctor, I'm sorry to bother you, but those dogs are still having sex on my front yard, and it's just making me very anxious." He said, "Lady, what can I tell you? Grab 2 garbage cans, let's bang them together. That'll separate them." About an hour later, she called him back. She said, "Doctor, I really hate to bother you, but those dogs are still copulating on my front yard." He said, "Lady, I'm going to tell you what, I'm going to call you right back. And as soon as you get the phone, would you lift up the window and tell the dogs the phone call's for them?" She said, "Now, how's that going to stop them from having sex?" He said, "Ma'am, I don't know, but you've stopped me 3 times tonight." The primary care physician, believe it or not, gets stuck with this kind of problem all the time. And as I said, if you take a look at the ECA data, 40% of the 25% of people who are actually in treatment are being treated by their primary care physician. Now, a family physician, and I worked in family medicine for a number of years, so I was conversant with some of this data. A family physician spends 5.3 minutes with each patient encounter, about 15.3 minutes if a patient has a, quote, mental disorder. If you actually then calculate out for any given work week for a primary care physician, 20% of their time, 1 solid day a week, is spent actually dealing with mental illness. This speaks volumes, though, about the lack of training that we give them in terms of medical school, where they only usually get 4 to 6 weeks on a psych unit, and then when they hit the residency program, maybe 1 month at the most, for a total of 10 weeks training for a part of their job that they're going to spend 20% of their time actually dealing with. As I mentioned, the primary care physician will spend considerably more time with the patient with a mental disorder, but surprisingly enough, oftentimes misdiagnose that disorder. In fact, one of the worst statistics is the one here at the bottom, that 75% of people who, quote, successfully commit suicide have actually consulted their primary care physician within 4 to 6 weeks prior to ending their life. Medical cost offset is defined basically as this, that it occurs when appropriate mental health treatment leads to a reduction in the utilization of other health care services, and that the actual cost of that mental health treatment is more than offset by the savings in terms of the decreased medical utilization rates. You know, those of us in mental health care have oftentimes been very apologetic at our success rate, and we have no reason to be. In fact, if you look at some of the present data, we actually do a pretty damn good job. In terms of the early treatment outcomes, for example, of panic disorder, we have about an 80% success rate. Bipolar disorder, manic depressive illness, about the same. Even such things as OCD, obsessive compulsive disorder. With pharmacotherapy alone, we have about a 60% success rate, and when you add behavioral therapies to that, you can actually increase your success even further. Compare that to some of the, quote, successes of medical treatments, for example, angioplasty, which is only about 40%, or arthrectomy, where you clear out the carotid artery. We only have a 52%, quote, success rate. So as a matter of fact, in mental health and mental illness, we actually should be quite proud of the fact that our success is quite good. Cost offset actually reduces a number of things. For example, we know it decreases medical utilization. The patient with clinical depression, and insurance companies know this, even though they insist they don't, will usually utilize medical expenditures 4 to 5 times more frequently than a person of the same age who has not suffered from clinical depression. We know that there are shorter hospital stays when you provide even brief psychological and psychiatric consultation. And these are not to patients who have psychiatric illness. Strain and his colleagues found that when you even provide consultation to a patient coming in for elective hip replacement, that you could substantially reduce the hospital stay and the complications post-operatively. We get fewer medical complications, earlier return to work, decreased absenteeism, which is a big thing among especially large employers, and there's some clear data that there's increased work productivity. In fact, there's a 34% reduction in healthcare utilization with only brief, and I mean 1, 2, 3 visits of psychological therapies. In fact, one study showed that there's about a 5-to-1 ratio. That is, for every dollar that you spend on mental health treatment, you'll roughly save $5.52 in terms of decreased health utilization. Mumford did a study, a meta-analysis actually some years ago, of all the studies that had been published at that time. And they found that 85% of the studies that were published at that point showed this cost offset effect. Now, I know I'm sort of preaching to the choir here because I'm sure most of you are familiar with this, and most of you actually see it clinically in your daily life. Let me hit you, though, with a startling statistic. Only 7% of benefits managers of major corporations in this country believe any of the things that I've said thus far. They don't believe the cost offset effect. They don't believe that early intervention actually reduces medical utilization. Physicians are often placed in a very awkward position, as our gentleman is here, and they're often asked to deal with these problems when they really are not adequately trained. They don't have the time or the tools to actually deal with it directly. I'd like to shift gears and talk a little bit about the anxiety disorder specifically, and rather than just talk theory, would actually like to show you some examples of what I mean by cost offset. Again, going back to the lifetime prevalence, 15%, like I said, it's really 20, because in the ECA studies, they only included panic, agoraphobia, OCD, simple phobia, and social phobia. They left out GAD, generalized anxiety disorder, post-traumatic stress disorder, and probably the most common disorder that family physicians see, which is adult adjustment reaction with anxious features. So they left out a couple of things, so we've got to adjust that number up slightly. Here's a real-life patient. This is a young woman who presents to her internist. He's a general internist in Memphis, Tennessee. He works at the St. Francis Hospital, where I have my office. And she presented with chest pain, some shortness of breath, some periods of what appeared to be lightheadedness and dizziness, and she presents with these symptoms in his office. On his first visit, PCP means primary care physician, he does a history and physical, and he did some very basic laboratory testing on this individual. Sum total, $125 for that visit. Reasonable. She came back a few days later. Symptoms were progressing. They were getting worse now. He went ahead and did an extended visit with her, went ahead and ran an EKG in his office, and also very appropriately went ahead and did a thyroid panel. We have a subtotal now of 170 for that visit off to the side. By the way, the thyroid did come back normal. The resting EKG was normal except for some very, very brief runs of tachycardia, some increased heart rate, but nothing to write home about. She came back a week later for her third visit. Her symptoms now were progressively worsening. In fact, her chest pain now was worse than ever and was coming on with bouts of pain. She was now getting very, very lightheaded with each of these. And he decided at that point that it was time to do another extended visit and to order a Holter monitor. For those of you that aren't familiar, Holter monitor is simply a battery-operated tape recorder you wear. It's an EKG that runs for the entire day, and it can give him a reading for that entire day of what her heart rate is doing. Of course, the Holter monitor is $393.25, and there was an interpretation fee because this is sent next door to the hospital where the cardiologist reads it, and it was read as normal except for, again, brief bouts of tachycardia. We now have a subtotal for that visit of $568.25. She came in with her fourth visit. At this time, she began to present now with more neurologic symptoms. She was now having lightheadedness, dizzy spell, periods where she felt she was a bit kind of out of touch with reality. And at that time, he decided to shift his focus and stop looking at a cardiac possibility, but rather it was more a neurologic possibility. Another extended visit. This time he did a CT scan of the head with enhancement. Of course, there's a radiologist, interpretive fee of $225 for that. So now we have $1,205. These are all real numbers, by the way, and this is a real patient. She now comes in for her fifth visit, and her symptoms are worse than ever. At this point, he does what any smart internist does, and that's buff and turf. That means he refers her somewhere else. And so he refers her down the hall to a neurologist whose office is across from mine, who does what any good neurologist would do, which is cover your ass. And so he decided to order an MRI of the brain, which cost $1,551.22, plus, of course, radiology interpretive fee of $305. We have now spent over $4,000 in medical workups on a patient who we still do not have a diagnosis for. We still have no idea what's wrong with her. She is still symptomatic. And oh, by the way, these numbers don't reflect the indirect cost of her problem. Remember now, she's been taking off of work for each of these tests. She's had to hire babysitters to pick up her kids from school. Her husband's taken off of work as well to get her back and forth to these tests. And we have a lot of attendant costs that I haven't even listed out here for you. And again, going back to our data, we probably could triple at least, certainly double, that $4,000 number in terms of the indirect cost that this has cost this woman over the past 4 weeks of her life, and we still don't know what's wrong with her. If you would, I'd like to start the first video. And so I'm going to show you an actual example of what this lady must have looked like when she presented first to the emergency room, which, by the way, was the place where she first made contact, who then sent her to her internist.
There's no rhyme or reason to it. Things you've done totally normally your entire life, all of a sudden, what in the world's going on?
So there wasn't anything that I felt building up. These feelings just came from nowhere.
It was totally out of character for me.
You never would have guessed.
I was elected vice president of the freshman class, cheerleader when I was a sophomore, just Mr. Everything.
I had no problems talking in front of people, doing anything. There was really nothing that bothered me.
I was never upset.
I was captain of the football team, class president for 3 years.
I was always the first one to lead the gang,
It was just utopia. Couldn't have been happier.
6 months later, I was petrified to go to a restaurant.
I mean, it was traumatic for me to go to the bathroom by myself.
I couldn't answer the phone.
I couldn't even make myself drive my own car.
And then I just virtually became a recluse.
Try to imagine the scariest situation you've ever been in.
The worst fear you've ever had.
and multiply that by about 10.
Times 100. Times 3,000.
You're facing death.
Someone's taking your heart and squeezing.
And you start trembling.
Your legs are shaking.
Your hands start sweating, your feet start sweating, you start sweating.
You think you're having a heart attack. You can't swallow. You can't walk.
And you just have this wave, go through your body.
It's there. You're dying.
Linda, I thought that was you. How are you?
Oh, I'm fine.
Cynthia, I work for Westbrook
Oh, of
Corporation.
course. Yes. Listen, I'm running very late for an appointment, so I'm going to fly.
Well, I'll go
okay?
with you. How are you?
Oh, I'm fine, but it's been one of those days. It's unbelievable.
So how long has it been since we've seen you? It must be 6 months already.
I think it is about 6 months. Yeah.
Everybody loves the work you did in our office.
Oh, thank you very much. Thank you for mentioning it.
Linda, what floor do you want?
16, please.
Is that the Hopkins agency?
Yeah.
Oh, that's a good company. I have a friend who works there. Have you been up to their offices before? Oh, no, of course not. Today's your first time. Listen, why don't you bring them down to our place and show them what a great job you did? Anyway, I'm sure you're going to do a terrific job. Do you remember Steve, my boss? Of course you do. Well, he talks about you all the time. It's just amazing what you've done. Linda, are you okay?
I'm sorry. What?
Are you okay? You don't look too well.
I don't know. Something's wrong. I have to get off this elevator.
What's the matter?
I have to get off. I have to get off right now.
Okay.
God. Oh my God. I'm dying.
Linda? Linda, you just sit here, okay? I'm gonna go get some help. Somebody, I need some help here.
Is it any wonder that this patient ends up in the emergency room? And is it any wonder that as a result of the symptomatology that she presents, which is basically the classic symptoms of panic disorder that oftentimes get overlooked. In fact, they're frequently missed to the point that 70% of patients with panic disorder will have seen roughly 10 physicians before it gets diagnosed. They'll usually see the ER physician one. They'll be sent to their gastroenterologist if they're having GI symptoms, cardiologist if it's cardiac symptoms, neurologist if it's primarily neurological symptoms, ear, nose, and throat specialist, endocrinologist, and the list goes on and on and on. And as a matter of fact, their workups, just as we saw a few minutes ago, start to exceed $10,000, $15,000, $20,000. Remember, our real-life patient a few minutes ago had already racked up close to $5,000 in testing, and we hadn't even really got started yet. These folks, that is patients with panic disorder, even though if you look at the data in terms of its epidemiology in the general population of only 1.5 to 2% of the general population, that doesn't tell you the whole story, because as a matter of fact, when you start looking at the clinical population numbers, that is, if you went to a cardiologist office, you'd probably find that close to 15 to 18% of a patient sitting in a cardiologist office this afternoon has this diagnosis, but it has not yet been made. One of the startling statistics I came across in looking this up was that if you take a look at just the normal cardiac catheterizations that are performed in this country every year, and there are roughly 200,000 normal angiograms each year at roughly $3,000 a pop, you're looking at roughly $600 million a year is spent on normal angiograms. Of those normal angiograms, clearly 1/3 of them are patients with panic disorder. 1/3 of that number clearly have panic disorder, which clearly has been not only undiagnosed, but also untreated as well. And so like poor Frank here, we have lots of times where these patients continue to panic. Not only is the cost, though, that we just saw a minute ago in terms of the medical cost of the laboratory workups, the referrals to many different specialists and so forth, but the social cost is also dramatic. These folks oftentimes will develop clear secondary phobic symptoms. If they've had their panic attacks primarily on the expressway, they will avoid the expressway. If they've been on elevators, they'll avoid elevators. If they've been while flying in an airplane, they will no longer fly. Wherever the panic attacks have begun to occur, they will clearly avoid those. But most importantly, we also know that these folks will abuse the emergency room, oftentimes coming 6, 8, 10, 12 times a year to the ER. And sadly enough, they will also begin abusing alcohol, because most of these patients, well, 27% of them certainly, will begin to abuse alcohol in an attempt to try to reduce the anxiety, especially the secondary anxiety, which is the anxiety between attacks. Of course, very often our managed care companies insist that we should not treat these patients. We should simply send them on to AA. I have a new prayer for you. This is the AA prayer. I'd like you to pay close attention to this one. This is my version. I know it's not politically correct, but so here what we see with panic disorder as a perfect example is that as the anxiety symptoms increase, we have the medical consumption and medical resources going up, not only in terms of the overuse of the medical system, but substance abuse as well, with all the associated problems with that. In fact, when I talk to business leaders, I oftentimes will present as a clinical example a gentleman who is a key person in their employment who is also depressed, suffering from alcoholism, and we actually track out what the cost would be of treating that gentleman, both in terms of an inpatient A&D program as well as very aggressive outpatient follow-up, including medication, psychotherapy, and so forth. And after I present this whole thing, usually to these businessmen and women, and I total out the cost of what that would be, most of them look at the bottom line and say, nah, it's really not worth it. We don't really want to spend that amount of money, $15,000, $20,000, whatever it is. And then, of course, my punchline is that this was the skipper of the Exxon Valdez, and it cost Exxon $5.2 billion to not have treated his alcoholism and depression. I know that, if you can focus that, I know that oftentimes our physician colleagues who are placed in the awkward position of having to treat mental illness feel like they're having their fiercest lawyers come after them going, sue him, sue him, sue him. And so they often give us as the reason why they, quote, miss these diagnoses is because they're practicing defensive medicine. That doesn't entirely wash with me, because one of the things we know about panic disorder specifically is 20% of these patients will go on to commit suicide. And so I don't think it's very good defensive medicine to have a patient die of a lethal illness at their own hands because you're worried about whether or not they've got a pulmonary embolus, which is way, way down the line on your differential diagnostic list. We have to do some basic workup, certainly, but we don't have to do $20,000 worth and totally miss what's wrong with the patient. One of the things that I think might be helpful, and especially for those of you who work a lot with the primary care physician, you might want to give some thought to this. There are some really good screening tools out there now. This happens to be one of them that I like. I use in my office called SDDSPC. That stands for Symptom-Driven Diagnostic System in Primary Care. It's a very short, very sweet little checklist system where the patient is presented with a list of simply yes/no answers to a number of symptoms, and this screening tool will provide them very quickly with a very nice little screen for basically 6 different things: panic, generalized anxiety, depression, OCD. It will also look at alcoholism and suicidal ideation. Had our example, the real live example I gave you a minute ago, had the physician had that tool or a tool like it available to him, the outcome might have been quite different. What I would suggest to you is the outcome might have looked like this: H&P, laboratory, basically the same. Yes, he should have done an extended visit on the second visit and probably should have used a little diagnostic test like this. This particular patient, and by the way, I later got to see this patient, so I used the diagnostic test, and I can tell you what she flagged on basically was panic disorder and depression. And sure enough, he would have seen that by the second interview. He still would have gone ahead and done a thyroid panel. That was still very appropriate to do, since many patients with panic disorder do have abnormal thyroid functions. But then what would have happened from there on, especially if he were in an HMO setting or some other kind of capitation setting, he actually might have gone on for the next 8 to 10 visits treating the patient using intermediate charges and actually combining appropriate medication treatment with this patient, and we would have probably been able to treat her for less than the cost of one CAT scan. As a matter of fact, when you look at the ECA studies looking at the actual outcome of just pharmacotherapy alone for panic disorder, it looks quite good, with 31% recovered, 50% having an intermediate course, and only about 18% having a downward course. This, by the way, these series of studies was only medication. When you combine cognitive behavioral interventions, a la Barlow and his work at SUNY at Albany, we find that you get even better numbers than these. So again, if we can get our primary care physician to begin to stop thinking just in terms of the laboratory test, or if we can at least now provide them with a different kind of laboratory test that might actually help them, we would actually reduce healthcare costs by having timely intervention. Now, I've used panic disorder as my first example this afternoon. I'd like to switch gears for just a second and use depression as another example. We know, for example, that the cost of depressive illness is just as bad as it is with anxiety disorders. We're looking at roughly $24 billion again in the indirect cost of this illness. We're talking about $12 billion a year. These are 1993 numbers, by the way, of direct cost. And we also, of course, have to figure in the cost of mortality, of income not earned. We know that this is a major issue for employers. They tell us that reduced productivity, morale problems, absenteeism, even accidents on the job, remember our Exxon Valdez example, are all extraordinarily costly to them. And in fact, if you look at the cost of depression, one of the things that's interesting, we spend about $44 billion a year on affective disorders, which is roughly what we spend on coronary disease as well. A substantial part of that cost, by the way, is antidepressant medications, which, interestingly enough, as I said earlier, 70% of the psychotropics in this country are written by non-psychiatrists. What we find oftentimes, though, is that there's actually an underutilization of antidepressants and an overutilization of anxiolytic medications. Now, this is one of the things we get into with managed care all the time, at least I do in my clinical practice. We'll have a patient with depression. I want the family physician that I'm working with to put the patient on an antidepressant. They want me to have the patient put on a generic tricyclic, an older drug, much cheaper per pill than the newer SSRI compounds, selective serotonin reuptake inhibitors. What they're not looking at, though, is a couple of different things. And this is something I think you ought to give some thought to in your arguments with managed care folks. There's a difference between price and cost. And we're not talking about here the price per pill. We're talking about the cost of treatment. Sure, a generic version of a tricyclic per pill is certainly cheaper per pill than a newer SSRIs. But let's look at the overall cost. First of all, only 40% of patients will actually take tricyclic antidepressants, leaving 60% who are terribly non-compliant. As a result of that non-compliance, your actual therapeutic rate of success is much lower because of the non-compliance. But that doesn't tell the whole story. This does. As a matter of fact, most of your suicides that are done by overdose are done with tricyclic antidepressants. And as a matter of fact, if you look at deaths per 1,000, they actually are the highest, along with the old MAO inhibitors, of just about any psychotropics we have. The SSRIs, there's not been a single case yet reported of an overdose by itself with an SSRI compound that proved fatal. And so the fact is that when we're looking at total cost, that is, whether the patient actually will get well, whether they'll actually benefit from the medication, whether they will stay alive through the treatment program, and so forth, we have to look at the total cost rather than just the specific price. I threw this slide in because I have no way of measuring what the work site violence cost is for untreated depression. I've talked as though panic disorder, depression, coronary disease are separate entities. Well, of course they are not, and a perfect example of that is that when you look at depression, clinical depression, diagnosable DSM-4 criteria depression, post-MI, that is post-coronary, we find a startling statistic. Almost a third of people who have had an acute myocardial infarction will have comorbid clinical depression. Now, they may have already had it before they had their MI. They may have it along with their MI, or they're going to get it right after they've had their MI, but they're going to have it. And what that has to do with long-term morbidity and mortality is quite interesting. As a matter of fact, if you have depression, your risk 6 months post-MI of mortality, that is of dying, is 4 times greater. Now, this is the most startling thing because when I talk to cardiologists use as the gold standard, folks, left ventricular dysfunction. If that left ventricle isn't working well, they can measure that with ejection fractions and all kinds of very interesting regression equations, and they can predict with surprising accuracy what your 18-month morbidity and mortality will be. What's surprising to them even more is when I tell them that depression as an independent risk factor is equal to left ventricular dysfunction. That is, if you have a patient who has clinical depression along with their MI, that's actually a better predictor of whether or not they'll live in the next 18 months than left ventricular dysfunction. For those of you that are familiar with the MMPI, this is a clinical presentation right here of a 52-year-old gentleman that I had the pleasure to treat. He's a senior executive with a hotel firm in Memphis. He did have an MI. Following his MI, he had angioplasty. Following his angioplasty, he came back into the emergency room about 6 times in a 2-month period of time with shortness of breath, dizziness, palpitations, and so forth. The ER doctor, who, by the way, happened to be one of my old family practice residents, picked up very quickly that this was not cardiac in origin, this was panic disorder, and he referred him on to me. It was panic disorder with comorbid depression, and here's his MMPI profile prior to treatment to show it. By the way, this man was almost on the verge of disability because he was finding it very difficult to go to work. Like our earlier statistics, he was beginning to abuse alcohol, and his job was actually beginning to suffer as a result of that. We embarked on a very aggressive treatment of medication. We put him on an SSRI, outpatient therapy. He was never hospitalized, and within 6 to 9 months, we see a normalization of his MMPI, a full return to work, and he's functioning fine. The fact is that we need to show our clinical colleagues, but more importantly, the insurance industry, that we actually are cost-effective in this realm. I've used panic, I've used depression. I'd now like to go on to using the next one, which is obsessive compulsive disorder. Before going into the statistics, though, what I'd like to do is to back up just a second and show you a brief tape, if you would, Kelly, of OCD, obsessive compulsive disorder. And the first thing you're going to actually see here is from that famous scientific show, Oprah.
Within this hour.
Yes, I could take it off. Yes.
Okay. Well, I think y'all better get up and get busy because it looks like it's been on there a while. It's going to take a while to get it off. I want you to meet Ken and Sue. As a child, Sue remembers the aunt who had a great living room just for show and never allowed anybody in. Well, guess what? Today, Susan has a living room all her own, which, according to her family, is more like a shrine. Her husband, Ken, calls it the Forbidden Zone. And here he shows us why.
Oprah, this is Sue.
Hi, Oprah.
Why don't you come on in and take off your shoes with us, and we'll give you a little tour of the house. Or at least the Forbidden Zone. Hey, Oprah, this is the chair that they were telling you about that no one's ever been allowed to sit in.
Well, that's because I don't want people sitting in it because then it would mess up the cushion and the tucking, and it's supposed to look nice.
In fact, I've never sat it until right now. I just wanted to see what this felt like, and it's really not that comfortable, so I haven't missed that much. This is my wife's china. It was kind of a special present when I was getting out of the service. And we managed to keep it in a box for approximately 20 years before we ever even took it out.
Finer things. You don't want to be using them every day.
Okay, and now we have this absolutely rock-solid oak dining room set. That, again, one meal since it's been owned. And
well, that's because I don't want the wood to be nipped.
this had to be an artificial plant because I'm not allowed to walk this far into the room over here to service it. And here's a set of love seats that we like to just vacuum. We don't sit in those either.
But he'd really like to sit in them. Would you like to try it this one time? I'll let you.
Yeah, this would be like Christmas in the middle of the year here. Look at that, huh? Look at that.
Don't get too comfortable.
Oh, I might leave sweat marks on this thing or something.
Oh,
Better
get up.
Oprah, we're going to do another test here right now. I know these things opened 5 years ago when they were installed, and this is another thing we're not allowed to do in here. You see this
Oh, be
window?
still my heart.
This is another thing that we're not allowed to do. See this? We're not allowed to do that.
Come on, close the blinds, close the blinds.
It's all
Oprah,
right,
they
it's
need
all
to be
right.
closed. Actually, Oprah, this is the first time that Ken or myself have been able to sit on this furniture actually together. This is really the very first time. And trust me, Oprah, it's going to be the last time. Do you see all these feet print all over the rug? Now I have to go vacuum all this up. I didn't even know that this would be possible. I bet you there's got to be 1,000 here.
Is this a serious disorder? It certainly is. In fact, if you look again at the ECA studies, we find that this is the 4th most frequent mental illness that you will encounter, behind alcoholism, depression, and the simple and social phobias. As a matter of fact, this is an extraordinarily costly disorder, both psychologically, socially, and medically. For example, when we take a look at the anxiety disorders, going back to the cost again, of $47 billion a year, $8.4 billion is actually spent, or 18%, on OCD. How does this manifest itself medically? Well, here's a perfect example. This is a 52-year-old gentleman who is an engineer by training, actually owns his own company, presents to the emergency room at St. Francis Hospital with abdominal pain. Are there any radiologists in the group that want to take a crack at this? They do a chest series. They find something looking very suspicious up in this area here, and some gas down in the gut. Anybody want to take a shot at it? OCD. And the answer is a hairball, trichobezor. This is a gentleman who has trichotillomania, which is a variant of OCD, along with many others. He actually pulls his hair out. He actually eats his hair. He's been doing that for several years, in fact, at least 10 years by his own admission. Hair, by the way, folks, does not digest real well, as you can see. It forms a very nice cast of the stomach, and just like your cat, he's got to somehow get that sucker out of there. Of course, he can't cough it up, so we call in the surgeons. Trichotillomania, anorexia nervosa is probably another perfect example of OCD spectrum disorder. Severe hypochondriasis. What is the true hypochondriac? The hypochondriac is the individual who is obsessively preoccupied with having a life-threatening illness for which there is no indication at all from medical tests, and yet they compulsively go back to different physicians, getting laboratory tests over and over and over again, racking up medical costs like you wouldn't believe. Self-injurious behavior. There's a condition called body dysmorphic disorder, which I strongly suspect Michael Jackson may suffer from. This is a disorder in which the individual, like the anorexic, looks in the mirror and sees some small flaw, and they see themselves as looking hideous, and so they continually go from one plastic surgeon to another, seeking surgical interventions. Individuals with borderline personality disorder, who we know have massive overutilization of medical expenditures, may be a version of this disorder. The social cost of this disorder, OCD, is also quite dramatic. In fact, 26% of people with classic OCD tell us it has destroyed an intimate relationship. This probably accounts for why over half the men with OCD are never married. 48% have lost friends. 57% say it prevents them from actually establishing new friendships. But look down here at the very bottom. 66%, two-thirds of these people, will have suffered from this disorder and have kept it hidden from their families, their friends, and I would suggest their family physician. The average age of time between onset of symptoms and first treatment is 12 years. This is a disorder that these people suffer from for 12 long years. Before the ECA studies, we thought this occurred probably less than 0.5% of incidence. Actually, it turns out it's 2.5%, 5 times higher. Again, it's the fourth most common type of mental disorder. The cost is also very timely. I'm going to show you here a slide or a video in just a second of a little boy. We're talking about 20% of patients tell us they spend up to 8 hours in their compulsive rituals, and 13% of people tell us they spend sometimes over 17 hours on their rituals. Let me go back, let me show you that MMPI for just a second. This is a gentleman who's a classic example of overutilization of medical expenditures. He's 40-some years old. He presented to his family physician with a 40-some pound weight loss. This gentleman had, and I wish I'd brought with me the slide showing his medical workup, literally tens of thousands of dollars in medical tests. He was worked up for AIDS. He was worked up for cancer. He was worked up for everything you can imagine. He had CT scans of the head and abdomen. He had MRIs of the head. He had 4 lumbar punctures. This man was worked up every single which way you can imagine. He finally made his way through all the specialists back to his family physician, who finally made the diagnosis of clinical depression. He was partly right. It was clinical depression, but also profound obsessive compulsive disorder. Had anyone taken a careful history, they would have found that this man was terrified of being contaminated. In fact, he had not eaten outside of his home for over 5 years. In fact, the only thing that he had eaten inside his home in the past 5 years were 2 things: Mueslix cereal, don't ask me why, I never figured that out, and Campbell's soup. Now, he would go to the grocery store and buy literally dozens of boxes of Mueslix. He would then take it home and very scrupulously investigate each and every box to make sure that it was not contaminated in some way. This is why he had never eaten outside his home in the past 5 years. He was terrified of getting contaminated. He wasn't sure exactly how. He didn't know whether it would be AIDS or whether it would be hepatitis or what it would be, but he knew he would be contaminated. And so as a result of that and his worsening OCD, just like Howard Hughes, if you'll remember, he became more and more reclusive. In fact, when I saw him on short-term disability, he was a school teacher. He had worked in an inner-city school in Memphis for most of his career, was very, very well loved and respected by the students, and now was no longer able to go back to work for 2 reasons. Number 1, the children would sometimes touch him, and number 2, he would have to eat outside his home. This gentleman had severe OCD. Kelly, if you'll show the video, this is an example, not of this patient, but of the same sort of symptoms in a child. And take a look at how this looks.
2, 3, 4, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 6, 7, 8, 1, 2, 3, 4, 5, 6, 1, 2, 3, 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 7, 1, 2, 3, 4, 5, 6, 7, 8, 9, 1, 2, 1, 2, 3, 4, 1, 2, 3, 4, 5.
How much does this young man cost society? According to our government, absolutely nothing, because up until the age of 14, you earn no income, and therefore your life has no real value, at least economically. But I think you can see that in terms of the human cost, this is one of the most terrible disorders that I've ever encountered, especially as it occurs in children, because these children very, very frequently fall further and further behind in school. They find themselves, because of their obsessive compulsive disorder, finding it difficult to get their work done. As a result, many of them are put into slower classes and certainly not up to their potential. As this disorder gets worse and worse, they become more and more reclusive, all of which it's very hard to put a dollar value on. It's also difficult to put a dollar value on some of the other costs of this disorder. We know that this disorder, OCD, probably accounts for over 25% of patients who are caught with shoplifting, kleptomania. We know that probably 18 to 20% of people who have obsessive gambling or pathological gambling have the OCD variant of this disorder. We know that there are probably lots of other OCD-type variations or part of the spectrum. And one of the last videos I'd like to show you is a clipping that was recently shown on TV just last week of another version of how OCD costs us tremendously. Kelly?
Ever since the invention of the shopping bag, women have been accused of turning shopping into a national sport where too much is never enough.
Ladies, Cartier, peach and daffodil.
But for all the stereotypes and jokes, what shopping has done to some isn't funny at all.
When you were at your worst, what would you do on a typical shopping day?
I would spend my time at the mall, my 8-hour day, and come home and then sit down and turn on the shopping channel.
And keep buying?
Yes.
This 39-year-old woman is a compulsive shopper.
Isn't that beautiful? I want it. That's gorgeous.
Her habit has caused such shame that she asked to wear a disguise and that we call her Lee.
So I definitely want one of those before I leave.
Now, what would be the difference, let's say, between somebody who's here and loves to shop and you?
They would buy one thing, I would walk out of the store with 10 things that I didn't need. Right.
While it may sound like a crazy habit, compulsive shopping has been the subject of serious studies in Canada, England, and the U.S. An estimated 10 million Americans have psychological problems when it comes to shopping, and perhaps not surprisingly, some 85% are women.
The way it makes me feel is very powerful.
Powerful?
Sure, because I can have whatever I want.
And for a while, Lee was the ultimate power shopper. At one point, she had 10 charge accounts, excellent credit, a savings account, and her own home.
How much would you spend on a typical day shopping?
I could easily spend $2,000.
$2,000 in one day? And this would be every week?
Lee says she spent more than $100,000, and this is just some of what she bought. Clothes, hundreds of pairs of shoes, and so much jewelry she could wear a different piece every day for at least 2 years.
Bummer of a birthmark, Hal. All three of the disorders I mentioned today, panic disorder, depression, OCD, probably have some genetic components to it. We know, for example, that with OCD, in general, you're looking at roughly a 63% concordance rate with monozygotic twins, that is, identical twins. If one has it, there's about a 63% chance the other twin will too. We also know that similar data have occurred for primary affective disorder, unipolar depression, and the same thing is true for the few twin studies that are out on panic disorder. I want to show you, though, a very interesting slide, and then we're going to get into looking at a model that I've developed for intervention. This is a slide of patients, 2 patients with severe obsessive compulsive disorder. Patient number 1 is on the left-hand side, and this is called a PET scan, positron emission tomography, where a radioisotope dye is actually injected. It's a glucose-based substance injected into the patient, and because of the glucose metabolism in the brain, it's absorbed in different areas of the brain. And if you'll look here where that little arrow is pointing right there, that's called the caudate nucleus. And for some strange reason, the caudate nucleus has an increased uptake in patients with severe OCD. 12 weeks later, and this patient was treated with fluvoxamine, or Luvox, which is a newer SSRI compound, we see clinical improvement, and we also see on a retesting of the PET scan an actual diminution in the uptake in that caudate nucleus. So for the first time, we have radiographic evidence that actually using an SSRI on patients with OCD produced not only clinical results, but radiographic results as well. Interestingly enough, if you look on the right-hand side, though, we have another patient, again with OCD, and there's that caudate nucleus right about there. It's also showed increased uptake. And again, after 12 weeks of treatment, we also show, along with clinical improvement, a diminution in the uptake of the isotope. Except this patient had no medication. This patient had intensive behavior therapy. And so we have here very compelling evidence that with the proper treatment, whether it's pharmacotherapy, whether it's behavior therapy, or what I suggest to you, a combination treatment, that we actually have a very good way of not only providing the patient with symptom relief, but we now have some radiographic evidence to show that we actually are doing the changes that we say we are. I'm going to follow up here and bring to an end the discussion today by sharing with you a model that I developed some years ago in my work in family medicine called the realistic model. And this is a model that was primarily intended for the primary care physician, the internist, the family physician, the pediatrician, and so forth, but also can be used by your graduate students and other frontline personnel as a way to conceptualize how to think about these patients coming in the door and what we might need to do in terms of an evaluation. When I talk about a realistic model, the A part is assessment. And my residents used to always come up to me and say, well, what's the best way to interview a patient? So I very humbly present to you today the best way to interview a patient. And you can do this very quickly using the best approach, where this little mnemonic device is get a timing, that is, get an idea of what the symptom presentation is in terms of the timing of the symptoms. Get, of course, a history that includes not only a historical count of the symptoms, but a family history as well. Remember, many of these mental disorders have a very, very strong family history. Find out what the environmental triggers or cues are. If you have a patient, for example, that tells you that their anxiety attacks, quote, come out of the blue, and that they're not set off by any particular stimulus, they're not set off by standing in front of an audience, they're not set off by flashbacks for post-traumatic stress disorder, they're not set off by all these things, and you hear that out of the blue type description, think panic disorder. Also then get your, very briefly, and I have some tapes to show how this can be done in 10 minutes, you get an idea of the actual behaviors the patient may be engaging in when these episodes strike, the emotions, the physical sensations, and the thought patterns. That is, what's the individual thinking, what images are going through their mind. And that if you do a very simple interview, and again, this is aimed at the primary care physician, if they'll do a very simple interview simply striking these areas, they'll find that using some very simple clinical pathways that we've developed, that they can actually come to the diagnosis of an anxiety disorder fairly quickly. The realistic part of my model then is the treatment part. And what I basically argued for is a stepwise progression in a treatment program. That the first level of treatment, and probably the most basic for any treatment, is to reassure the patient. For example, using the patient with panic disorder, they do need some very specific reassurance that they're not having an MI, they're not having pulmonary embolism, they're not having all of these other life-threatening illnesses. They also need to be reassured that they've got panic disorder. And then you move into educating them and explaining to them exactly what that disorder is. Now, some of you may take more of a pharmacotherapy approach. Some of you may take more of a behavior therapy approach. Some of you may take what I like, which is the combined approach. But with whatever approach you take, you then try to provide an educational format for the patient to understand and to explain their symptoms. You then do some very specific advice giving. And this is something we were often taught not to do, especially in classic psychotherapy. But in primary care, you're often asked to give specific advice. For example, you want to advise the patient to get off of caffeine in a gradual way. You want to advise the patient not to start an aerobic exercise program, because aerobic exercise will often induce panic disorder. You want to advise the patient, contrary to the ER physician's advice, not to breathe into a brown paper bag when they're having a panic disorder, because that increases CO2, which sets off the panic alarm system. You have some very specific advice you want to give them. You also have at your disposal, and again, we're going through a progression here, some limited interventions. These are things like relaxation training, stimulus control procedures, and so forth. Many of these are cognitive behavioral interventions that are very workable within a short-term psychotherapy framework. And then finally, last but not least, we have specialized therapies and consultation. I would argue that the primary care physician, be it an internist or family physician or pediatrician, has no business trying to do this last 10% of my model. This is the specialized therapy that mental health specialists are all about. This is the intensive psychotherapy of the individual, of the couple, of the family perhaps, but this is something that the family physician ought not to even try any more than they should try cardiovascular surgery. The fact is, though, that if you look at my model, that in the kinds of cases that they see, they probably can handle a good 50 to 55% with just using reassurance and education and a little advice giving, and then they need to refer on the rest. And there's a real art, of course, to referring, which we won't go into, and there's a real art to providing specialized therapies. This doesn't happen to be one of them. The realistic model is an acronym for progressive treatment. It is a referral paradigm. It teaches you when to stop doing what you want to do and learn to refer the rest. It's a good model for training, especially for training the primary care physician. It's not a protocol. You don't simply say, first visit I'm going to reassure, second visit I'm going to educate, third visit I'm going to advise. No, it's not that sort of thing at all. It's a model to conceptualize the progressive levels of treatment. It's certainly not a substitute for good clinical judgment, and it's certainly not the only skill you need. I really don't like it when managed care companies ask me to do this sort of thing, where Doreen breezes through Chapter 9 in veterinary school by no matter what the problem is, go ahead and shoot the horse. There isn't just one treatment for every patient. There are, I think, we have developed some clinical pathways or clinical guidelines for a variety of things. I know you probably get as frustrated as I do that we don't know what the guidelines are that they're using to judge our treatment. And they won't tell us because it's proprietary, they say. We're trying to get legislation, by the way, in Tennessee to not allow that. We'd like to see some legislation passed that anybody offering managed care in Tennessee has to make available to us, the clinician, the actual guidelines that they're using, and also to standardize once and for all those damn forms they make us fill out, because everyone has a different form. Timely mental health care really will reduce overall cost. Again, if you look at the direct cost in terms of morbidity, mortality, and we haven't even discussed the welfare and justice system, the mental health problems of this country are enormous. We do, however, have very good treatments. And just as a review, our success rate is every bit as good, in fact, substantially better in some cases, than classic medical treatments of other medical problems. To achieve an offset, you basically have to do three things. You have to have a proper diagnosis, you have to have an effective treatment in place, and you have to have some way to do evaluation of your outcomes. And basically that's what this slide shows, is that there's a stepwise progression with a feedback loop, of course, into the system. I know the managed care companies have really gotten onto us of late. They really want us to get our act together. They really want us to make diagnoses quicker. They really want us to make treatments faster. In fact, they want patients in and out of the office in 2 visits, if not shorter. I'm going to end then with a diagnostic system that you all can use that is very efficient, very brief. In fact, it's so efficient, so brief, you really don't need to have the patient in your office. All you need to do is look out your window, watch how they park their car. Panic disorder. They will park their car, they usually have a panic attack, rush right on home. You make the diagnosis, send in the bill. It's very appropriate. Don't even have to see the patient. Managed care companies love this. Very efficient, very efficient. OCD, even more efficient. They'll park and repark their car a million times. They'll try to get it straight. Watch them, send in the bill. Don't even have to see the patient. No follow-up necessary. Substance abuse. They always come in the exit. They sideswipe a few cars, crash through your clinic door, they race off. You can make the diagnosis, don't need to see the patient. And of course, my favorite is multiple personality. They come in different cars. Thank you very much for your time and attention. I'll be welcome any questions. Questions? Yes, ma'am. There's some stuff that was published by Greenberg about 2 years ago that looks at that. That's the slide that had the $47 billion a year. And I can't remember what it was per patient, but I'll give you my card, and if you'll drop me a line or give me your address, I'll see if I can get you that Greenberg article. By the way, it's sometimes interesting how this stuff presents. I was listening to a speaker the other day on migraine headaches and the cost of migraines, and it's quite interesting. You can look at it from a number of standpoints. You can look at it from the standpoint of medical utilization. You can look at it from the standpoint of absenteeism. You can also look at it from the standpoint of work productivity. One of the things that they found with migraine patients was that you get to a point where it does not decrease, or does not increase the sick day utilization to have recurring migraines. And the reason for that was very simple. These folks had already maxed out their sick days. And so they were coming to work, closing the blinds, closing the doors, turning off the lights, and barfing in the garbage can with their migraines all day. They weren't productive at all. Okay, they weren't doing a damn thing, but they weren't taking a sick day. And so it's very difficult sometimes to be able to assess, what is the work productivity measures that we're looking at here. Those indirect costs are very hard. And see, with mental illness, if you look at the data in terms of direct and indirect cost across the board, and whether we're looking at depression, panic, OCD, schizophrenia, all of them, your indirect costs are almost always 3 to 4 times higher than your direct cost. Our direct cost, folks, are not that great, okay? But the indirect cost of not treating these illnesses is extraordinarily high. We run into one of the biggest arguments I have is I have a program called the Butt Kickers program, which is a smoking cessation program, and I cannot get employers in the Memphis community to send patients to that program. It's a set fee program. It has a set price. There's 10 visits. We use SSRI medications because we find that with patients who have long history of smoking, many of them have untreated depression. If you try to get them to stop smoking and don't treat the depression, the relapse rate is terrible. Anyway, not to go into the program, but the bottom line is none of the employers will pay for the program. And it's a lousy $450 program, and they won't pay for it. And yet they'll pay for the MI that patient will certainly have a few years down the road as a result of their 3-pack a day smoking. So the insurance companies sometimes, they just don't think through the long-term cost of this stuff. When I mentioned this to one of the insurance companies, he said, no, we know that. He said, but we also know that probably in 2 years that same person is not going to be under our coverage, so what do we care? And that's exactly their view of this. It doesn't matter to them because the enrollees are going to change that much. They're not in this for the long haul anyway in treating this patient. So this idea of primary or secondary prevention often falls on deaf ears. Depression is probably the worst, especially if you have a patient with chronic recurrent depression. And if you have the person with double depression, you know, dysthymia with depressive episodes, managed care companies will drive me crazy with that. Because I'll have them on a medication, we'll be involved in treatment, we get them back to full functioning, we're 6 months into treatment, and they want me to stop treatment. And I say, why do you want to stop? And they say, well, you know, you're done. You said she's better. Well, by all the rating scales you used, she's better. I said, yeah, she is. Why do you want to stop now? The University of Pittsburgh studies, and Ellen Frank up there showed, that if you continue treatment, especially for chronic recurrent depression, you can prevent relapse. The data are there. No, they insist on stopping treatment. You stop treatment, the person relapses within 6 months, and we're right back into it again. And what really, really pisses me off is that what's really happening here, if you believe the kindling effect in depression, is every time that happens to a patient, it's harder and harder to treat the depression. We're going to start painting ourselves into a corner. I see somebody shaking their head, because medications that once worked for the first or second episode stop working. And now we find ourselves getting backed into a corner because they won't let us treat the depression. And it aggravates me because this is like diabetes, glaucoma, hypertension, rheumatoid arthritis. I mean, I can go through the list. These are chronic illnesses. We can treat them, we can manage them, we can even cure them, but they'll come back if you don't let us continue to do good work. How to get on my soapbox? It just ticks me off. Other questions? Yes, sir. That's a great question. Now, for those of you who couldn't hear it, the dual diagnosis programs. I'm sorry, I'm not up on the literature on how well those programs work. It would seem to me, just theoretically, that would be the way to go when you've got the dual diagnosis patient. We also have another kind of dual diagnosis patient that I am more familiar with, and that's the patient who has chronic emphysema and depression, or the child who has chronic asthma and panic disorder. And when you have the dual diagnosis of a medical condition with a comorbid psychological condition, the data are very clear. That medical condition will not get any better unless you treat the psychological condition. And your rehospitalization rate, your length of hospitalization time, your medical complication rate, on and on and on and on and on, goes way up unless you treat the medical illness. I've got a patient right now who I'm going to work up the numbers because he was referred to me for depression. His primary symptoms were GI, and as we're finishing up the treatment, I wanted to go back and ask him what he had done the year before he came to see me, and I was absolutely astounded with all the tests that he has had done. And we're still adding them all up, but right now the subtotal is $28,000 in testing that he's already had the year before treatment. Now that his depression has been treated, he's doing fine. He has not had a single test this entire year and is in better health than he's been in for years. We have not done, I don't think, a very good job, though, in mental health in taking that kind of data, whether it be anecdotal or whether it be group research data, and showing it to those benefits managers that are making these critical decisions. And as long as companies, and some of the big companies in Memphis like FedEx and Promise and some of the others, they do carve-outs. I'm sure most of you have companies here that do carve-outs. They carve out the mental health benefits package. They then sell that to either Medco or U.S. Behavioral Health or American Biodyne or some other managed care company who oversees that mental health treatment. The problem is they don't ever talk to the medical side of what's going on. And so here we have a patient over here with, let's say, depression, who has had 6 MRIs over the past 2 years. And they want to stop this treatment, and I can tell you from the cost offset data that we can save you money over here if you allow this treatment to continue. But see, they won't see that data because when the treatment is stopped and the person goes back into the other system, they're on the other side. The numbers they don't work with. And so all those carve-out programs, I think that's one of the reasons why they don't believe cost offset. They don't see the data. They don't see the numbers. And one MRI, folks, I mean, stop and think about this. If you had a charge of $100 and you had a patient in maintenance and you were seeing them once a month, you could see them for 12 months, $1,200. That's the cost of one MRI. Yes, ma'am. If you had said that a year ago to me, I would have said, no way. This year, I'm about ready to say, yeah, I think you may be right. That if you have a program that will address the mental health needs, and I guess a substantial number of these folks, and we haven't even talked about the geriatric patient, but how many of those folks out there who have untreated depression, who have been called Alzheimer's? I had one patient last year who was admitted to the hospital for, quote, an Alzheimer's workup. She had severe OCD. And we treated her, and she's back to functioning. She's living at home with her husband and visiting her family. But she was this close to a nursing home placement because of how debilitating her OCD was causing. But yeah, it's going to have to take a system, though, that pays attention to the fact that we don't have this separate mind-body. You know, Descartes, for as smart as he was wrong. Okay, the mind and body are actually interconnected. I want to end with one last joke. I don't think we have all the answers in mental health, but I got to leave this. I heard this joke the other day. I collect little kid jokes, and I heard a great joke about the little boy. He's walking in the pharmacy. He's looking in the drugstore, very, very baffled. And the pharmacist said, "Can I help you?" And he said, "Yeah, I'm looking for sanity napkins." And the pharmacist said, No. You mean sanitary napkins?" He said, "Yeah, that's right. He said, "Well, maybe if you can tell me who you're buying these for, I can help you select some." And the little boy said, "Oh, they're not for me." He said, "They're for my little brother, Billy. He's 2. The pharmacist said, "Well, that's really interesting. Why would you think your brother needs sanitary napkins?" He said, "I don't know, but they said on television, if you wear these, you can ride a horse, ride a bike, go swimming." He can't do any of that stuff. Thanks again for coming. I'll stick around to answer any questions.